Okay, thanks for joining today's webinar on recognizing the signs and symptoms of pediatric medical traumatic stress in patients and families. This is the second in a series of three webinars in partnership between Minnesota AAP and the Alongside Network. And I'm going to pass it over to Jen now, the founder and CEO of Alongside Network.
Thanks a lot, Hannah. Really glad to be here. Thanks to the people joining in person, and then excited to know that lots of folks will also be watching this online later. We're very happy to be with you today. I'll just give a quick introduction to myself and then the work of Alongside and a little bit about how we got here, and then we'll pass it to Dr. Tess Thomas. Um, so my name is Jen Aspengren. I'm the founder and CEO of Alongside Network. And our work is really focused on raising awareness around pediatric medical traumatic stress. And this series is really feeding very closely into the work that we do. Tess, if you just advance to the next slide. So a little bit about how we got here. My background has been 20 years of working in systems change nonprofits. So my master's is in public policy, come with sort of a systems focused lens. And then when my youngest son was 7 months old, he had a major surgery that saved his life and also left him as a really different kid than we had brought to the hospital. So when we brought him home after an extended hospital stay, he essentially scream cried for like 9 months straight. We kept bringing him back to the surgeon, back to the pediatrician, to the emergency department in the middle of the night, and everyone kept telling us, he looks great. This kid is really thriving. And we knew that that was true physically, but there was sort of a whole other piece that must have been being missed, and we couldn't understand what was going on. Eventually, our pediatrician sort of said, I wonder if this is like a post-traumatic stress thing. And she was right. And also just hadn't had the training to know what to do with a family presenting in her office with that question. So it took us many more years until we could figure out sort of what happened to him. What did that mean for his brain development and sort of the pathways that were developed at that young age? And then what could we do as a family to support him, to sort of get to a point of thriving later in his life. In the meantime, I began sort of digging around and trying to understand what did this mean and what did this look like for other families that didn't look like ours. We're a white family navigating this system in our first language for a lot of reasons. Would expect if the system is going to work, it would work for us, and really saw that that wasn't the case. So began to understand. There are over 20 years of research on the problem, pediatric medical traumatic stress. And there are a handful of solutions that have popped up around the world, but have rarely spread beyond the researchers who developed them. So started alongside to really begin to model what it can look like, to have those solutions available and normalized both for families and for providers. So we're really excited to partner with the Minnesota AAP on this series to just bring this information out to more providers. And then would also invite all of you to share the Alongside Network with the families that you work with. So we offer direct supports for families as well as trainings for providers. So I'm happy to introduce Dr. Tess Thomas. Um, Dr. Tess Smith Thomas is an assistant professor at the University of Kentucky and Kentucky Children's Hospital. Dr. Smith Thomas received her PhD in clinical psychology from the University of Kentucky in 2021. She also completed her internship in health psychology and her postdoctoral fellowship in pediatric psychology at the University of Kentucky. Currently, she provides clinical care to children and families experiencing difficulty adjusting to an injury or illness. Dr. Smith Thomas also collaborates with the Center for Pediatric Traumatic Stress to implement trauma-informed care throughout the medical setting. Dr. Smith Thomas is also committed to conducting applied, clinically relevant research alongside and related to her clinical work, with the overall goal of improving medical care for children. More specifically, Dr. Smith Thomas's research focuses on examining the utility of temperament in screening for mental health risk and to inform tailored intervention targets. And secondly, examining structural vulnerabilities that contribute to mental health risk and inequities in accessing mental health treatments. And third, developing and testing preventative programs that target structural vulnerabilities to shift the pathway and prevent the development of mental health symptoms and improve mental health equity. So, as you can see, Tess is an amazing partner for us in this series. Very happy to have you here, Tess, and I'm going to pass it over to you.
Wonderful. Thank you, Jen. And thank you so much for kind of sharing your story and the story of Alongside. Today, we are really going to be focusing in on identifying the signs and symptoms of pediatric medical traumatic stress in patients, caregivers, and siblings. We'll talk about recognizing kind of very varying clinical presentations, as well as describing risk factors for the development of pediatric medical traumatic stress. As has been mentioned, this is part of a three-part series. Um, I'll start with a bit of a recap of what we covered in our last webinar on this topic. Last time we really talked about, we started with just defining pediatric medical traumatic stress as a set of psychological and physiological responses of children and their families to pain, injury, serious illness, medical procedures, and invasive or frightening treatment experiences. And then we also talked about SAMHSA's trauma-informed framework, which includes realizing the widespread impact of trauma, recognizing the signs and symptoms, which we'll be focusing on today, and then responding and resisting re-traumatization. So our last session really focused in on this realize, the first R, and we learned that about 75% of high school students report experiencing one or more adverse childhood experiences, and 20% experience four or more. And so, what that means is that the majority of our patients who walk through our door for medical care will have experienced at least one or more potentially traumatic experience before ever even entering the medical system. We learned that medical traumatic stress specifically is pretty prevalent. About 30% of children experience significant traumatic stress reactions following injury or illness. 20 to 30% of caregivers experience those persistent traumatic stress reactions, and about 15 to 25% of siblings experience persistent traumatic stress reactions. We know that about 80% experience acute symptoms, and that then about 30% persist on. So today we are really going to focus in on the second R, and as you can imagine, our third part of this webinar will focus in on the final two R's, responding and resisting re-traumatization. So when we think about recognizing the signs and symptoms of medical traumatic stress, we can think about kind of our four classic symptom categories for PTSD. And so that includes re-experiencing, which might include things like intrusive thoughts or memories about an illness, injury, or medical procedure. That might include nightmares or flashbacks. This could include distress, such as becoming really emotional, crying, angry, short of breath, panic symptoms related to reminders of the illness or injury or medical event. We think about our second bucket as hyperarousal, including feeling really easily startled or jumpy. This like overall hypervigilance or just being on guard. Sometimes this can come across as increased irritability, struggling with concentration, focus, or sleep. Really kind of this like heightened sensitivity to environmental stimulus. Our third bucket is avoidance. So this might include things like avoiding thoughts and feelings about procedures, treatments, or an illness or injury. This might be like avoiding conversations about illness or injury or medical condition. And then finally, we've got our fourth bucket, which is changes in cognition or mood. And this includes things kind of like those persistent feelings of shame, guilt, anger, confusion, fear, sadness, worries, all of those things, right? This might include negative thoughts about ourselves, people, or the world. Feeling really detached or withdrawn from people or emotions. Decreased positive emotions or interest in previously enjoyed activities. All of these things kind of fall into that changes in cognition or mood category. And so these are kind of those four buckets of symptoms that we are looking for when we think about pediatric medical traumatic stress. So just to dive in a little bit deeper, I'd like to give you all some really kind of concrete examples of what each of these symptom categories can look like. We'll start with just looking at patients, then we'll move into caregivers, and then we'll talk about what some of these symptoms might look like in siblings as well. And so for re-experiencing, um, we might have someone say, sometimes I feel like I'm back in the hospital reliving when I got my diagnosis. Or every time I hear that beeping sound, I'm reminded of my chemo treatments and my heart just starts to race. Or this comes up a lot. Like I could just be watching TV or at the store and thoughts about getting hurt just like pop into my mind, right? Or another example is my child draws pictures about being in the hospital, right? So in younger kids, especially, that re-experiencing will often come out as nightmares or come out in like medical play in some form, drawing pictures, acting it out, those kinds of things. When we think about avoidance for our patients, that might look like trying not to think about cancer diagnosis. And anytime my parents talk about it, I leave the room. Or I stay away from the playground where I fell and broke my arm because it reminds me of that day. Um, or I avoid doing my treatments altogether and taking my medicine because it reminds me that I'm sick. Um, and then finally, my child never makes eye contact with the doctors. And I've noticed that sometimes when doctors come into the room, they act like they're sleeping. This is a big one. I've seen several patients who are sleeping when the doctors come into the room. That's like a really clear indicator of some avoidance, right? And when we think about these symptoms, we can kind of think about how this one in particular, especially that avoidance, can really impact medical care. Um, because if you're avoiding your treatments, then that may have an impact on your overall physical health and your relationships with your medical team. Hyperarousal in our patients, some examples of that are I jump every time the door to my hospital room opens, or I can't focus even when I'm doing things I enjoy, like playing video games, just having a hard time focusing. Even though my doctors said I'm all better, every time I feel sick, I panic, right? And then changes in cognition and mood for our patients might look like kind of these overall thoughts like, my illness is all my fault, and if I did something different, this wouldn't have happened. Or ever since the accident, I feel scared every time we leave the house. The world is just really dangerous. Um, or I don't really feel anything anymore. I don't even want to spend time with my best friend. And so I think that that's an important example to highlight because I think when we think about changes in mood, we're often seeing things like those like heightened emotions, like that increased irritability, or kind of behavioral concerns, kind of lashing out. But this can also look like just feeling really numb. So switching over to caregivers, some examples of re-experiencing would include every time I close my eyes, I see my son in that hospital bed. Or when it's quiet and I'm alone, my mind begins to race thinking about my son's illness. Or sometimes I sob and feel like I'm hyperventilating. Um, Another example is when my daughter wears that blue unicorn shirt, I'm reminded of my daughter's injury because that's the shirt she was wearing when the accident happened. Avoidance for our caregivers might look like I drive the long way to work to avoid seeing the hospital. Or I've not told any of my friends or extended family about my child's illness because I don't want to talk about it. Another example is I've stopped going to my own medical appointments because the office just feels too overwhelming. Or my spouse leaves the room every time my child's doctor starts talking about additional medical procedures or treatments, right? So, kind of that overall, like trying to just avoid or escape situations that remind us about the medical condition. Hyperarousal in our caregivers might look like I feel like I have to stay on guard for the next bad thing to happen. Or I have less patience and I'm more irritable towards my spouse ever since our daughter was in the PICU. Or I'm constantly monitoring my child's health not to miss anything again. I think that one can be really common. And then changes in cognition and mood may look like feeling guilty about a genetic condition that was passed down to a child. So my child has cystic fibrosis because of me, and I feel so guilty. I'm worried about what this injury means for my child's future, or it's hard to feel any happiness while my child is so sick, right? So again, looking at like kind of those changes in worldview and the thoughts that we're having, as well as changes in mood. And then switching over to our siblings, some really kind of clear examples of re-experiencing would be I play doctor at home. My dog broke her arm and had to go to the hospital just like my sister did. Or I still have nightmares about the day my little brother was diagnosed with sickle cell. Avoidance may look like I don't tell anyone that my sister has kidney disease and pretend that everything's fine. Right? Like that, like if I don't think about it, if I don't talk about it, it's not real. I try not to think about my brother's bike accident at all. Or whenever I see commercials about hospitals or healthcare, I change the channel. Hyperarousal in siblings could look like struggling to focus on school, even subjects that they've previously enjoyed. Um, this is another example. I'm nervous about getting hurt like my brother, so I'm extra careful everywhere I go. So kind of just being on edge, being overcautious, right? Another example is it's hard to sleep when my sister's hospitalized. And then for our siblings, changes in cognition and mood might look like this. Once my sister got sick, I have been afraid that I'm going to get sick too. Or I just want to be left alone. I don't want anyone around me anymore. My brother got sick because of me. We got in a really big fight and I wished something bad would happen. So I really want to kind of just highlight some really clear examples and all of these differences and how these symptoms can present and what they can look like across both patients, caregivers, and siblings. Um, and I also want to just highlight that what we know about medical traumatic stress is that it does look different in different people. And there is no like clear indicator to our providers whether or not a child is going to exhibit or is experiencing that pediatric medical traumatic stress. Of course, there are signs and symptoms that we can look out for, but I think it's not always the obvious. And so I think sometimes kids who are a little bit more oppositional or vocal about things, those might be noticed more frequently, and those symptoms may be attributed to something else, like a behavioral disorder of some sort, or personality disorder of some sort, even. But often those more like oppositional or avoidance behaviors in the medical setting can be an indicator of medical traumatic stress. And then I always worry about a little bit about some of our kiddos who are more internalizing versus externalizing, because they're the ones that they may be complying, but they may be like suffering emotionally on the inside and not on the outside. And so those kiddos can often get overlooked as well. And so just really highlighting that the presentation can vary drastically. And so it is important to kind of know those four buckets of symptoms and know those various examples. So that way you can kind of start to recognize some of those things in your patients and their families. So let's kind of just talk about what is actually happening physiologically in our bodies when we are encountering a stressful event or potentially traumatic event. And I know that we talked about this in our earlier series that was on secondary traumatic stress as well. But I want to just really carefully highlight this again, that when someone is experiencing a stressful event, the amygdala, which is kind of the area of our brain that contributes to emotional processing, sends a distress signal to the hypothalamus. And this area in our brain really kind of functions as the command center that communicates with the rest of our body through the nervous system, so that the person kind of has this energy to then fight or flee. And sometimes you'll see that fight or flight response in your patients. And so to kind of break this down a little bit further, a stressful or dangerous situation occurs, and various parts of our brain and body are communicating with one another about those external stimuli. And so after that stressful or dangerous situation occurs, our senses send those signals to the amygdala, which then communicates with the hypothalamus, which then uh, sends a signal to our nervous system that releases stress hormones in our body. Um, and those adrenal glands kind of pump epinephrine, which is a stress hormone, through our bloodstream, which signals that fight or flight response. And that then can cause increased heart rate, blood pressure, and our bodies kind of experience all of those like really intense physiological symptoms of stress. And so when we are thinking about recognizing the signs and symptoms, I think it's really important to acknowledge that physiological component and how that can impact how our patients are presenting as well. To dive in a little bit further into the nervous system specifically, we've got kind of these two components of our nervous system, the parasympathetic and the sympathetic. And our parasympathetic nervous system is really responsible for like our rest and digest um, mechanism. And that kind of is what signals for people's bodies to kind of rest and slow down when needed. And then the sympathetic, on the other hand, is like this like go button, right? It aids in that fight or flight response. And really, our goal is for our nervous system kind of be in balance. When a stressor occurs, that sympathetic system is going to be activated, but hopefully it returns to kind of that baseline level and goes back to the equilibrium. However, with chronic stress or trauma, that system can kind of get out of whack, and our sympathetic system can become a little bit overactivated, which then can lead to a lot of physical and mental health concerns. And so, again, what's happening in our body is important to pay attention to and can impact how our patients are presenting. We did talk about this some in the last part of this series as well. But I do want to kind of just again highlight who is at higher risk for medical trauma. And so this was a table that was put together through CPTS, or the Center for Pediatric Traumatic Stress. And it's kind of like a little bit of a checklist that you can utilize to determine for children or patients and caregivers if they're exhibiting any of these risk factors. So at the top, we have a perceived risk of life threat. This is a big one. We know that it is not necessarily like that subjective opinion of, it's not necessarily the objective kind of experience, but more of that subjective experience that plays a role in whether or not someone is going to experience medical traumatic stress. So it's not if we as doctors think that their life was in danger. It's more so if the patient and the caregiver or the sibling thinks that the patient's life was in danger. That is a huge risk factor. If they're experiencing early traumatic stress symptoms, so kind of in that acute phase, in the really early phase right after a medical event, if you're experiencing some symptoms, that is a good predictor on whether or not the symptoms might persist. For children specifically, more experiencing more severe levels of pain is a risk factor. Being exposed to really scary sights and sounds in the hospital is another risk factor. And then being separated from caregivers during or after the trauma, we know is also a potential predictor of medical traumatic stress. And then finally, for both caregivers and children, a history of previous traumatic experiences. And so in the last session, we talked about all of these different types of traumas that can occur and some of those ACEs. And having a history of those traumatic experiences can make you more likely to experience medical traumatic stress when you encounter a medical event. In addition to that, a history of any sort of mental health problems is also a good predictor. And then lack of peer support. And then specifically for our caregivers, having experienced other life stressors or disruptions. So, if we're struggling financially, if we lost a job, if we're going through divorce or separation, those kinds of things can be a predictor on caregiver medical traumatic stress. Now, what I will say is that the research shows that there's not like one single perfect predictor here. And there is constantly more research being done to help us better predict which kids are going to develop medical traumatic stress. But what I think is really important to know as providers is that there are some risk factors and that might make our patients more likely, but no one is immune. And most people who interface with the medical system are going to be impacted in some way, shape, or form. And even if they don't experience those like persistent or clinical levels of PTSD symptoms, that doesn't mean that they're not impacted in some way by medical traumatic stress. And you'll often see some of these symptoms present in many of your families and patients. Okay, so now I want to spend some time going through a case example and kind of talking through what are some of the signs and symptoms that we see for this patient. And so this is John and his family. John is a 7-year-old with cystic fibrosis or CF, and um, he is not eligible for modulator therapy. And so he does have about one hospitalization per year due to exacerbations that require IV antibiotics. Um, and so, what we know about John is that at clinic visits, he is regularly presenting with elevated blood pressure. Um, However, when he goes to his primary care provider for physicals or ear infections and those kinds of things, his vitals are all within normal range. So at CF visits, he's got that high blood pressure, but otherwise his blood pressure looks fine. Um, John is also typically pretty reserved in CF clinic, but his parents say that outside of CF visits, they can't get John to stop talking. He's really extroverted. He's a very talkative kid, but at clinic, he is very quiet. Um, we also know that he cries quietly before his throat swabs and his labs, and then quickly requests to go home as soon as it's over. Um, and so he is not necessarily like overtly like yelling or fighting those parts of his visit, but he is getting emotional. Um, the other thing that is happening with John is that his parents report that occasionally, not every night, but occasionally, John will have night terrors, yelling, no, please stop. And this is really distressing for his parents. They go into his room, they see him yelling like this, and then he kind of just like goes back to sleep on his own. And then in the morning, he like has no recollection of it. His parents remember, and they ask him about it, but he does not remember this happening. And his parents say that during his hospitalizations for those exacerbations, that this increases drastically. It's happening more frequently when he's in the hospital. Um, John also does really, really well with his treatments and doing them at home. But at school, he is saying that he's not hungry and he doesn't want to eat. And he shares with his mom that he doesn't want his friends to know about his CF. And as part of CF, you have to take your enzymes when you're eating. And he does not want to do that at school because then he feels like his friends would be asking him, what are those pills? Why are you taking them? Um, are you sick? Might start asking a lot of questions. Um, Switching over to John's younger sister, Sarah, she is 5 and she does not have CF. She's a relatively normal, healthy child. And when John is in the hospital, though, Sarah clings really tightly to her dad when he brings her to visit John. And Sarah really frequently asks her parents for reassurance that John's CF is not contagious and that she can't get it from him. She worries about this a lot. And it seems like she does okay, but then as soon as he's back in the hospital, she's asking again, like, can I get CF? Like, why does John have CF and I don't have CF? Is he going to give it to me? She's frequently checking about that. The other thing that's happening when John is in the hospital is their parents are getting frequent messages from Sarah's teacher that she's acting out in class and having a lot of conflict with her peers. And typically, she doesn't really exhibit any sort of behavioral concern. She is normally does really well at school. She's 5 now and in kindergarten, but prior to that, even with like her daycares, this was happening too, where during John's hospitalizations, Sarah's kind of having some behavioral difficulties. Now we'll switch over to John's mom, Sylvia. And so Sylvia, she really refuses to leave John's room during his hospital admissions. Dad is like regularly offering to like switch out with mom and kind of offering like, hey, I can even just come for a little bit. You can go home and take a shower at home, or you could go take a nap. Like I'll stay the night one night. Dad's really trying to get mom to have a little bit of a break. Or even like, hey, I'm here right now. Why don't you go down to the cafeteria and have a minute to yourself or anything like that? And mom just simply refuses. She says that John needs her and that something bad could happen if she were to leave the room. On top of that, as soon as providers come into the room, Sylvia like jumps up and goes right to John's side. And this is happening even if it's just like nurses coming in for like a quick vitals check or even like a meal tray delivery. Like as soon as that door is opening, mom is up and at him. This is happening even in the middle of the night, like during nighttime vital checks and things as well. And Sylvia also blames herself for John's CF, and has shared with you, the provider, that after John was diagnosed, she became really depressed and sought some counseling, which did help. But she does continue to find it really difficult to connect with other caregivers who don't have a child with a chronic illness. And so I want to kind of just dive into, all right, what signs and symptoms of medical traumatic stress are here? And we'll kind of go one by one through John, Sarah, his sister, and his mom, Sylvia. So with John, he is obviously experiencing those increased vitals at his CF visit. He's got that high blood pressure when he comes into clinic. And this could definitely be a sign of hyperarousal, especially because this isn't occurring outside of those CF visits, right? So when he goes to his primary care provider, his blood pressures look great, vitals look great. He's not experiencing that there. But so this could definitely be a sign of that hyperarousal and that like physiological process associated with trauma that we were talking about, right? Those night terrors that he's having, that could be a sign of that re-experiencing. Him being really quiet and reserved in clinic kind of shows that he has some changes in his mood. The refusing to eat eat at school so he doesn't have to take his enzymes could be a sign of avoidance, right? And so he's kind of touching on some things from each of those 4 buckets and likely probably experiencing some significant medical traumatic stress. Tara, his sister, on the other hand, so she's got like that clinginess to dad when he's coming to visit John in the hospital. She's got this like really kind of hyper awareness about and fear about catching CF that she's kind of fixated on at times. And then her behavioral concerns during his admissions could all indicate some of that like hyper arousal as well as the changes in the mood and cognition. And then finally, Sylvia, John's mom. So kind of that jumping as soon as someone comes into the room, that indicates that hyperarousal. She also was experiencing like this fear that something bad could happen if she were to leave the hospital, as well as blaming herself. We see that like depression after the diagnosis and kind of isolating herself from others. These things all kind of show some changes in cognition and mood. And so for Sylvia and Sarah, mom and sister, they're not necessarily touching on all of those buckets of symptoms, but they've got some of those symptoms here and there. And what I do want to just kind of, again, highlight is that just because they're not experiencing something from every single one of those buckets doesn't necessarily mean that they're not being impacted by medical traumatic stress. Um, and it seems like here they definitely are. And so I'm sure many of you are thinking at this point, okay, great. We've talked really in depth about the signs and symptoms. And we've also talked about just recognizing like this widespread impact of medical traumatic stress. And so now it's like, okay, great. What do we do with it? And so, not to leave you hanging, but that will be the focus of our next part of this series. And so, the next training will be on November 20th. And here is where we will talk about really applied strategies for responding to pediatric medical traumatic stress and resisting re-traumatization. So those final two R's in the four R's of SAMHSA's trauma-informed care model. And so I really hope that you will join for that session because I think that is going to be one of the most beneficial sessions of the three. But in the meantime, I'm happy to take any questions that anyone has about anything that we've covered today.
Looks
Okay.
like there aren't any questions, but that was really, really helpful, Tess. Thank you. That was terrific.
Thank you.
Thank you
Very
everyone for
Awesome.
joining today and for watching online later as well.
Thank you.
Thank you.